Go through ranges of motion and so like with all aspects of the spine, you want to go through, check range of motion, check palpation. So the first thing you're going to do is you're going to first figure out probably the best way to kind of hold your patient's head. Now, somebody's head is like where they store themselves. Like that's where you identify most with yourself. Like my pinky, I don't feel like is as much myself as my head. So be very careful and very respectful of the head. So you probably want to grab underneath the occiput and kind of circle around the ears. This is kind of like the most neutral way of holding the head. So this is what we're going to use for rotation. So rotation, you're going to do the whole neck. So you're just going to rotate one way, come back to midline, then rotate the other way. And you want to appreciate, is it more restricted on one side or the other? Does it move fluidly? Does it kind of flow when you're moving it around in space? Next thing you want to do is you want to do lateral bending. So maintain the same hand position and bring ear to shoulder. And same thing, before you go to the other side, come back to midline. If you try and just sweep around to the other side, they only engage their neck muscles because their head, it's like too much floaty head time. It's just, they don't like it. So come back to midline, then bend to the other side. And appreciate the lateral bending. Is it equal on both sides? Does it flow smoothly? Next thing you want to do is the walk like an Egyptian move that I think he might have showed you in class. Mm-hmm. Okay, for this one, it's a different grip on the patient's head. So you basically are going to grip on the parietal bones. So you're going to come down on the top with a couple fingers underneath the occiput. You're going to grip like this. And you're going to be compressing the cervical spine and extending the head forward like that. So this is called the cervical stair step because you can kind of see there are a few separate steps that the neck goes through. So you want to go, is that smooth? Is it well coordinated? Is it painful? Remember, you're compressing the cervical spine, so it's kind of like cervical compression. You know, you could get a positive result from a disc or a nerve root that's being pressed because they don't like that. Okay, then the other thing you're going to do is that's been all of our general kind of gross assessments. Then you're going to go and you're going to do segmental assessment. So what you're going to do is you're going to come in with this part of your hand. Now this part of your hand right here, basically from the MCP to the PIP, this is your operating portion of your hand. You're going to use this for your assessment and your adjustment. So what you're going to do is you're going to come in and you're going to flex the neck laterally at different segments using that part of your hand. So does the neck flex laterally equal at all segments? Well, no, it doesn't. There are some areas where it feels a little restricted. Then go to the other side and come in and feel the lateral bending. Does it feel equal on all sides? No, this side actually feels a lot more free and mobile than the right side. There's some restrictions in here. So we've done segmental lateral bending. Then you want to do segmental rotation. So again, you want to kind of keep this operating part of your hand there, and you're going to use that as kind of a fulcrum to rotate her neck at different segments. Okay? Do that on both sides. And feel for that rotation. Is the rotation in the spine equal on all segments? Are there any restrictions? Okay. So once you've done all of that, you can kind of put it all together in what Dr. Nick likes to call the snake, which is basically you're going to come in with your operating fingers, like on both sides, and kind of feel. Is her neck able to laterally bend? Is it freely mobile on all spots? So like right there's a little baby restriction, and like right up here there's a little baby restriction. So I can just feel that by the lateral bending, the fluidity of the neck. Then so basically the two gold standards for the neck, you need to be able to do all this assessment, but the two most useful parts are your palpation and your the snake thing that I just showed you. So your motion and then your palpation. So you want to feel down the patient's neck. Now what you're going to feel for, where you want to feel, is going to be, you have two main kind of straps of muscles that are on the posterior and lateral side of the neck. You have your erector spinae muscles, then you have a gap, then you have your sternocleidomastoid muscles. It's in the gap between the sternocleidomastoid muscles and the erector spinae muscles are where you feel the facets. So you're actually feeling the facets, whereas in the rest of the thoracic spine and lumbar spine, you can't really feel the facets themselves. Here you are. And what are you feeling for? You're feeling for posterior rotations. In the neck, mostly it's going to be posterior rotations. So the vertebra is shifted like that, and I'll feel something poking back out at me on the left, or it's going to be like this, and I'll feel it poking back out at me on the right. It'll feel like a little P. Oftentimes it's a little P, and you can use your STAR assessment acronym, and like, is there pain? Is this sensitive? Does it feel restricted? Is this tender to the like, communicate with your patient, because the tender areas more than likely are going to be the spot. So is this tender? Yeah. So you'll get a feel for it. Sometimes it's subtle at first, but imagine it's just kind of like no bigger than a pea, and that's the posteriorly rotated facet. Okay, so you found all your stuff. The other thing you can do, and I should have mentioned this up front, is when you first sit down, you can kind of body-wide assess your patient's level of relaxation and any body-wide restrictions. So you do that just by pressing back and forth on the shoulders. And look, I can see the force is transmitted down to her feet. I can see her feet moving. I can see that her neck is moving. I can see that her thoracic spine is moving and her legs. So she's like fairly relaxed. You can also work out some trigger points. You have your trapezius trigger point right in the middle of the traps. Then you have your levator scapula. It's kind of on that superior medial border of the scapula itself where it attaches. And you can work out some of those trigger points. You can work out the suboccipital trigger points. You can do your little bridge to relax the patient. These are things that I do commonly before I adjust the patient, because some people, they just don't relax that easily. So once you've done all of that, and this is going to take you a little bit. This is like, half of the battle is finding out where you're going to adjust. The other half is adjusting. So once you find a spot that you want to adjust, I'll show you how you're going to do it. So, important thing to note is that you always take the slack out of any adjustment, and this is no exception. The difference here is that oftentimes we're doing slack up towards the head. We can't do that, obviously, in this case. What we're going to do is slack to the throat. What that means is basically anterior slack. So I find where I want to go, and I want to slack up so that this part, the operating part of my index finger, ends up on the facet. So I'm going to dive lower and slack up to that point. Does everyone kind of conceptualize that? So here's the spot I want to adjust. I'm going to dive under and then slack up. Next thing I'm going to do is I'm going to laterally bend her towards me, rotate a half turn away. And this is locking her out at that segment. Okay? One thing to note is I'm keeping her head on the table. I'm not picking her head up. Some people pick the head up and adjust like that. The problem with that is that if you don't really have them securely, the patient won't relax, and you'll be able to see it in their SCM muscles. They'll be all tensed up, and the patient's not relaxed. The adjustment's not going to go that well. So I would recommend you have your your indifferent hand under the patient's head, and it's basically resting on the table. So her head's resting on your hand, resting on the table. So she feels secure, she feels grounded, and then your operating hand is going to actually be doing the adjustment. I want you to note that nothing really goes on with this hand. This is just here for support. I'm not actually using this to manipulate her head at all. The entire manipulation comes from your active hand. So what you're going to do, and you need to stand for this, by the way, is you find the spot, you slack up to the throat, right, so that the operating part of my hand is on that facet, and laterally bend towards, rotate away. Then I'm going to get up, and I'm going to get into position. It's basically kind of a squat position. You need to ulnar deviate your hand. So you need to lock out your ulna against your metacarpal bones so you form that solid, kind of that solid rod that you're going to use for your force. Because what I'm going to do is I'm going to be pushing straight lateral. Okay? So in the cervical spine, there are 3 vectors of force that you can use. For mid-cervical, you can kind of just go straight across. Upper cervical, you're going to arc up this way. And lower cervical, you're going to arc that way. We've seen this in other aspects of the spine, like the thoracic spine. In the middle thoracic, you go straight down. Upper thoracic, you're going straight back. Similar thing. So what you're going to do, so you find the spot, you take your slack up, you laterally bend, you rotate. Now, so my hand underneath her is just sitting there very passive. My hand on top has a little bit of force. I'm pressing in to get the slack out. I'm ulnar deviated. Then when I make my thrust, it's going to be like this. So I'm using my whole body. I want you guys to realize that you don't have to do this just with your arms. When people fail, they're doing this like push thing. Use your body. You have this like nice solid stance. Rotate your hips, and that's going to facilitate you being able to do a thrust in the vector that you choose. So use your hips, rotate your hips. I'll show you what it looks like. And slack up, laterally bend, right there. So that wasn't that much force, because I had her in place, and then I used my body and just a little flick. So, let's see, am I missing anything there?